Major depressive disorder, or more commonly known as depression, is a mental disorder characterized by at least 2 weeks of misery, apathy, low mood, and many others. According to the World Health Organization, depression is the leading cause of disability worldwide, with more than 264 million people affected, making it without any doubt an incredibly real and serious issue.
But what is exactly going on inside the brain of a depressed person? Well, going back to the good old days, Hippocrates believed that it was caused by the imbalance between four humors that physically exist as bodily fluids, and that sadness was caused by an excess of black bile. Even if this theory might sound out of this world, he wasn't technically wrong. A modern Hippocrates would have said that depression is caused by a chemical imbalance in the brain. Indeed, this hypothesis is known as the monoamine hypothesis. It stipulates that depression is caused by a deficit in monoamine transmission like serotonin and noradrenaline in certain regions of the brain. But first, let's see how neurotransmission works. Let's take the noradrenergic synapse as an example. When an action potential arises at the terminal ending, noradrenaline is released into the synapse. Following this, the neurotransmitter has four different fates. It can bind on the postsynaptic receptor, it can act on the presynaptic autoreceptors, it can escape the synapse and diffuse away, or it can be pumped back into the presynaptic terminal by the reuptake transporter. Once reabsorbed back, noradrenaline can be recycled or it can be broken down by an enzyme called the monoamine oxidase. Monoamine oxidase inhibitors like iproniazid work by blocking the monoamine oxidase enzyme. Since less noradrenaline is metabolized, more will be released in the synapse. The tricyclic antidepressants like amitriptyline work by blocking the noradrenaline and serotonin reuptake transporter. Therefore, with less neurotransmitter pumped back, more can build up in the synapse. Finally, just like their name indicates, selective serotonin reuptake inhibitors like fluoxetine work the same way as tricyclic but block selectively the serotonin transporter, thus increasing serotonin in the synapse. SSRIs are the most commonly used drugs to treat depression because of their good efficacy, their few adverse effects, and their good pharmacokinetic profile. However, not everyone responds to SSRIs treatment, and it has to be taken for a long period of time to achieve mood improvement.
But people do not want to keep taking the medication forever. So, how else can we treat depression? Here is one possibility. Ketamine is a drug that was initially approved as an intravenous anesthetic agent, but during the last 2 decades, subanesthetic doses of ketamine have been marketed as an emerging treatment for major depressive disorder. It acts within 2 to 4 hours after its administration, and its antidepressant properties can last up to 1 week after a single infusion. It also has a good pharmacokinetic profile. What a wonderful drug, but how does it work? Ketamine is a non-competitive NMDA receptor antagonist, meaning that it blocks the action of NMDA receptors by binding to a different site than glutamate or glycine. But wait. How does this have anything to do with monoamines, and how can it act as an antidepressant? The short answer is that we don't know. But here is one hypothesis. Researchers believe that ketamine has a higher affinity for a specific type of NMDA receptors that are present on GABA inhibitory interneurons. So when ketamine blocks these receptors, it causes the disinhibition of NMDA receptors, leading to a glutamate surge. This glutamate surge will activate the AMPA receptors, which will lead to a series of cascades that will increase the amount of BDNF. But what is BDNF and how does it relate to depression? BDNF promotes neurogenesis in the central nervous system by binding to tyrosine kinase receptor B on target neurons. Post-mortem studies on patients who suffered from depression have shown that BDNF levels are significantly reduced. This causes the shrinkage of the hippocampus, an important brain structure involved in the regulation of emotions.
This brings us to the next question. If ketamine is a good antidepressant and that it increases BDNF in the brain, is it possible to use other drugs that increase BDNF levels to treat depression? In fact, preliminary data using animal models has shown that isoflurane, another anesthetic drug, might also have antidepressant effect by increasing BDNF levels. Isoflurane binds to different receptors in the CNS with different affinities. It acts as an agonist on inhibitory GABA A and glycine receptors, but can also act as an antagonist on excitatory NMDA, AMPA, and nicotinic acetylcholine receptors, causing burst suppression patterns in the EEG of the patients, which is also observed when treating depressed patients with electroconvulsive therapy. But unfortunately, we're still far from understanding everything about depression, and we definitely need to do more research to characterize the underlying molecular mechanisms of ketamine and isoflurane. So hopefully one day we will be able to identify a good molecular target and design an antidepressive drug that specifically acts on the BDNF pathway and leads to mood improvement in a short period of time and without any side effects. So thanks for watching and stay healthy.